Good morning, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The title of my lecture today is Cesarean Scar Pregnancy. What we wanted to discuss today, the definition of cesarean scar pregnancy, its incidence, its etiology, different types, whether endogenic or exogenic, grading, how to diagnose by clinical presentation and by investigation, by color Doppler ultrasound and by MRI, and how to treat patient with a scar pregnancy with different lines of treatment from expectant or medical or surgical or combined treatment. Let us start our journey. Before we start, you should look at this picture. This is the site of previous cesarean scar, and this is the gestational sac implanted in the site of the scar here, as you see here, and this part here. So, what is the cesarean? What is the cesarean scar pregnancy? Gestational sac, as you see in the picture, implanted in the scar from previous cesarean section, as you see here in the picture, gestational sac implanted in a previous cesarean scar. It was first discovered by Larson and his colleagues in 1978. This pregnancy was 6 weeks pregnancy, and they did surgical evacuation for this pregnancy, but the patient complaining of post-operative abdominal pain and continuous vaginal bleeding. Till they did laparotomy and they discovered that there is trophoblastic tissue inside the scar of the previous cesarean section. They did excision and they sent for histopathology, and they discovered that there is still remnant of pregnancy inside the scar. Long time passed, then Remben and his colleague in 1990 discovered by ultrasound the first cesarean scar pregnancy at 7 weeks gestational age. Because of the advantage of the ultrasound, especially the transvaginal ultrasound, allowed doctors to see this type of abnormal pregnancy. What about the prevalence? 1 in 2,000 pregnancies constitute the cesarean scar pregnancy. But actually, we can say that true prevalence is higher than that, because some cases pass the unnoticed and the unrecorded with miscarriage. The incidence of cesarean scar pregnancy reported to occur in 0.15% of women with previous CS, and representing 6.1% of all ectopic pregnancies after cesarean deliveries. Currently, the incidence of cesarean scar pregnancy is increasing rapidly because of the increase in cesarean section rate. Also expected to increase because all over the world, the cesarean section rate is increased. The exact etiology is not clear yet, but it is suggested that there is myometrial disruption or scarring due to cesarean section, and this disruption is a predisposing factor for this ectopic pregnancy. Invasion by the implanting blastocyst, as you see in the picture, this is the niche of the previous scar. Implantation of the blastocyst in this area and the development of the sac, as you see here, with vascularity of the trophoblastic circulation and the placental circulation later on, occur. So till now, the cause is previous scar of cesarean section. Maybe due to another scar, but the accused one and the most common one is the previous cesarean section scar. The risk of recurrence has been reported as 5% in women with one previous cesarean scar pregnancy treated by D&C. The other picture here shows another type of scar pregnancy, the exogenic type, as you see bulging outside the surface of the anterior wall of the uterus. So we have two types, endogenic type and the exogenic type. Please look to the picture on the left side. This is the endogenic type. Implantation occurs at the scar, but the gestational sac grows towards the cervicoisthmic or uterine cavity. And this is one of our cases in Mansoura University Hospital. The sac grows toward the cavity here. So we call it endogenic type. But if the sac grows toward the myometrium, toward the wall of the bladder, it is called exogenic type, as in the picture on the right side. So the gestational sac is deeply embedded in the scar and the surrounding myometrium and grow towards the bladder, and it carries a risk of earlier rupture, of course. Another grading by Lin and his colleague in 2018, 4 grades. Please look to this picture. Grade 1, the depth of the gestational sac in less than half thickness of the lower anterior corpus. This is the uterine wall, this is the anterior wall of the uterus, and this is the bladder, and this is the gestational sac. In less than half of the lower anterior wall of the uterus, it is grade 1. More than half of the lower anterior wall of the uterus is considered grade 2. While grade 3, the gestational sac bulge outside the myometrium and the uterine serosa. While grade 4, the gestational sac becomes amorphous tumor with rich vascularity here. So we have 4 grades according to Lin and the colleagues in 2018. And the same by ultrasound picture as you see. How can we diagnose? By the clinical presentation and by transvaginal ultrasound and abdominal ultrasound and the color Doppler and the MRI if needed. The patient may present by no symptoms, asymptomatic, and may be discovered accidentally during doing ultrasound, or present with slight lower abdominal pain and tenderness and mild vaginal bleeding, or severe acute pain with horrible vaginal bleeding, or may be diagnosed during surgical evacuation for missed miscarriage. This is the first to be diagnosed during surgical evacuation with severe bleeding, or the patient may present with shock and collapse, indicating that rupture may happen intra-abdominally with internal hemorrhage. The complication may be hemorrhage, shock or collapse, or uterine rupture, or if the pregnancy continue, may be placental adhesions, placenta accreta spectrum, or preterm labor. The investigations is important to diagnose, and I wanted to say that many doctors may be confused with the diagnosis and they may diagnose the case as a normal intrauterine pregnancy, especially with endogenic type, or as a missed abortion or inevitable abortion, or gestational trophoblastic disease, or even some doctors may diagnose the case as a cervical pregnancy. I wanted to say that early diagnosis is very important using transvaginal ultrasound, because with the increasing of the gestational age, the diagnosis becomes more difficult, reaching the most difficult if exceeding 12 weeks of pregnancy, especially with endogenic type. So it is better to diagnose the case early to be accurate. We wanted to use ultrasound with 5 to 12 megahertz group, high resolution ultrasound to diagnose cesarean scar pregnancy. Color Doppler use is very important because it allows the visualization of the surrounding organ and the distance of the myometrium between the gestational sac and the bladder. As you see here, the distance of the myometrium between the gestational sac and the bladder is about 2.3 millimeter. Less than 2 millimeter is dangerous. So there is certain criteria. If you find this criteria, you diagnose cesarean scar pregnancy. What is this criteria? Please look to this picture. The first picture here. The uterus by TBS should be empty. The cavity of the uterus is empty. The cervical canal also is empty, and the internal os is closed. The sac at the site of the previous cesarean scar, the sac should be at the same side. With the thin myometrium, the myometrium between the sac and the bladder is thin. And there is also negative organ sliding sign. What is the organ sliding sign? By transvaginal probe, try to do push the probe. If the sac changed its position or move with the pushing of the vaginal probe, so it is positive sliding sign. If it is fixed in place in the site of the scar, it is negative organ sliding sign. So here in scar pregnancy, it is negative. It's still fixed. With the use of color Doppler, there is increased vascularity around the scar and around the gestational sac. This is related to trophoblastic circulation and the placental circulation, as you see here. So, denoting that this is scar ectopic. So, all these criteria by ultrasound and the color Doppler is diagnostic for scar pregnancy. MRI can help in diagnosis, but it is expensive and they need expertise. But can diagnose also, and it is very important to detect the myometrium thickness between the sac and the bladder. And if it is 2 millimeter or less or more, you can define it by MRI. And as you see in the picture, this is the empty uterine cavity. This is the ectopic pregnancy at the site of previous cesarean scar, bulging, okay, by MRI. What are the lines of treatment? Really, different lines of treatment is present, and sometimes you are in need for combined treatment. Like what? Like methotrexate systemic injection, 50 milligram per square meter surface area, intramuscular, or suction evacuation by MVA after giving methotrexate by 1 week, or doing uterine artery embolization, then followed by suction evacuation later on, or doing hysteroscopy and do resection, as in this picture, and do resection to the scar ectopic pregnancy, or do laparotomy for exogenic type of cesarean scar pregnancy and wedge resection of the scar and the pregnancy, or doing laparoscopy and wedge excision of the ectopic and scar by laparoscopy, or using focused, highly focused ultrasound ablation, or using vaginal surgery by dissection of the bladder through anterior colpotomy and excise the site of the scar and the ectopic pregnancy and do repair to the wall of the uterus. So I have different lines of treatment, or I may do nothing like expectant management, which is rarely used. So let us know what are the factors influencing the treatment options. Actually, maybe something related to the cesarean scar pregnancy itself, or factors related to the patient, or factors related to the facilities in the place, in the hospital. According to the factors related to cesarean scar pregnancy, like the HCG level, the gestational age, what is the size of the cesarean scar pregnancy mass, what is the type, is it endogenic or exogenic one, and what is the myometrial thickness between the gestational sac and the bladder wall, and if this sac and the embryo is viable or not. What about the patient factors? Patient factors include the fertility wishes in the patient. She wanted to preserve her uterus and she wanted to be pregnant later on. The clinical presentation of the case is regarding symptoms and signs and the amount of bleeding. Acceptability of prolonged follow-up and the patient is compliant or not. Surgical risk factors if present. What is the response to initial treatment, and if there is any associated lesion in this patient. What about the facilities? The facilities include, is there any surgical expertise in the field, and the facilities like well-equipped hospital with blood bank and machine and interventional radiology and the operative theater, everything well equipped or not, availability of hysteroscopy, laparoscopy, and so on. Monitoring facilities, is it available in the hospital or not? So all these three main group of factors affecting my decision about the treatment options. Look to this table, please. Different lines of treatment here, like expectant management, medical management by methotrexate, local injection after aspiration of the sac with methotrexate or other embryocides, embolization to the uterine artery, chemoembolization, or surgical management like suction evacuation, like hysteroscopic resection, like vaginal excision and the resuturing with anterior wall, like laparotomy or laparoscopy treatment, like high intensity focused ultrasound ablation, or lastly hysterectomy, all this under surgical management, or maybe combined or sequential management, as in many cases I need to use combined or sequential management, as we'll see. Let us start with the expectant management, rarely used because it is risky and dangerous, because the patient is at high risk of massive hemorrhage and may reach up to hysterectomy, and the patient, if insists to continue pregnancy, may be exposed to placenta accreta spectrum and preterm labor and horrible bleeding and cesarean hysterectomy even. So you should discuss with the patient about all these risks. Also, if the chance is given, it is only for endogenic type, because exogenic type is risky to rupture. Sometimes if the fetus is unviable, is dead, and the HCG level is low, spontaneous resolution as any other ectopic pregnancy may happen with the expectant treatment. What about medical treatment? The first important one is the methotrexate, but it is given if HCG is less than 5,000 international units per liter and the pregnancy is less than 8 weeks to give the best result. The dose 1 milligram per kilogram or 50 milligram per square meter surface area. I can give single dose or 2 doses or multiple doses. Some advise 2 doses, one at day 0 and one at day 4. And you should do follow-up by HCG and the size of gestational sac and resolution of the mass of cesarean scar pregnancy. Don't forget to do CBC and the liver function test and the kidney function test when you are using methotrexate therapy. Another line of treatment is to do aspiration to this sac, then inject methotrexate inside in the same dose, 1 milligram per kilogram, or inject another embryocides like potassium chloride or etoposide or hyperesmolar glucose. Then do follow-up by HCG level and the size of gestational sac for waiting for resolution of the cesarean scar pregnancy mass. Another line of treatment is to do embolization of uterine artery on both sides by injecting gel foam and the methotrexate. And please look to this picture. Here is the uterine artery after femoral castration. This is before embolization, and in this picture the uterine artery here is closed after embolization, and of course you need intervention radiology available in the hospital. Surgical treatment like suction evacuation by MVA, as you see in the picture, is done if the myometrium thickness at least 2 millimeters, because we are afraid from rupture of the uterus and we are afraid from horrible bleeding. Some advise after evacuation to insert a Foley's catheter and inflate the balloon with 30 ml of saline at the side of the previous scar to decrease the chance of occurrence of hematoma, and they keep this Foley's catheter inside for 24 hours as a hemostatic measure. Another line of treatment advised by Timur Trich and published in 2017 with the use of cervical ripening double balloon catheter. As you see in the picture here, this is the cesarean scar pregnancy, and here after insertion of the double balloon catheter, the first balloon inflated inside the uterine cavity, while the second balloon inflated at the area of the site of scar pregnancy. And keep it for average 3 days. Then follow up with color Doppler ultrasound. As you see, the sac will disappear and spontaneous resolution of the cesarean scar pregnancy occur. Another surgical line of treatments to do hysteroscopic resection, as in this picture. This is the scar pregnancy. Okay, we do hysteroscopic resection, and sometimes you are in need to give the patient methotrexate before doing hysteroscopic resection, or do uterine artery embolization before doing hysteroscopic resection to minimize the bleeding which occur during this resection. Another surgical procedure is transvaginal resection by doing anterior colpotomy and dissection of the bladder and excise the site of the scar and the ectopic pregnancy, and then resuture the anterior wall of the uterus associated with transcervical suction curettage also, or vacuum aspiration. Another line of treatment, which is a promising line of treatment, is using high intensity focused ultrasound, which was used by Diego Gang in 2015, published a research about 53 patients received one session of high intensity focused ultrasound ablation. The patient well prepared, taking liquid for 3 days, doing enema before, then exposed to this ablation, and followed by hysteroscopic suction evacuation under hysteroscopic guidance. And as you see in this picture, this is the cesarean scar pregnancy after ablation, and after suction evacuation under hysteroscopic guidance. This is the result of the picture of one patient with coagulation of any bleeding vessel. This method gives a very successful results for all 53 patients, and this machine is a promising in treatment of scar pregnancy. It is also used for management of uterine leiomyoma as one of the lines of treatment, and now it is a promising machine for treatment of cesarean scar pregnancy. Another line of treatment is laparotomy or laparoscopy by doing wedge resection, excise the ectopic mass and the scar, and then suture the anterior wall of the uterus during laparoscopy, as in this picture, or doing hysteroscopy and do resection of the cesarean scar pregnancy, or doing combined laparoscopy and hysteroscopy, or sometimes you may need to do hysterectomy as a life-saving procedure or the last option. This is during laparoscopy. This is during laparotomy. We are doing wedge excision of the scar and ectopic mass and repair of the anterior wall of the uterus during laparotomy, and this is during laparoscopy and this is hysteroscopic resection in this picture. So we sometimes need either combined treatment or sequential treatment, so we need more than one line of treatment. Combined treatment means what? I am using more than one modality of treatment within a short interval. Like what? Like doing uterine artery embolization followed by suction evacuation after 24 hours. This is called combined treatment because I use two procedures within very short time. Why I'm using uterine artery embolization before suction evacuation? To decrease the possibility of occurrence of bleeding or horrible bleeding or the need for hysterectomy. Or use sequential treatment. Sequential treatment means I'll start with one modality of treatment, then after a certain period, like 7 days, I'll use another line of treatment. Like what? Like giving methotrexate systemic 50 milligram per square meter intramuscular. Then after 7 days, you can do suction evacuation with MVA. Or giving methotrexate injection and do hysteroscopy or laparoscopy after 7 days. Or other operative procedure. So this is called sequential treatment. This is a very interesting case with heterotopic pregnancy with cesarean scar pregnancy diagnosed by transvaginal ultrasound. Please look to this picture. The blue arrow denoting the normal intrauterine pregnancy in the cavity, while the yellow one denoting the cesarean scar pregnancy. So I have two pregnancies, but one normal inside the normal uterine cavity and the one inside the scar. How to manage such condition? By termination of this cesarean scar pregnancy by aspiration guided by ultrasound, then in local infiltration with potassium chloride or hyperosmolar glucose and do follow up until spontaneous resolution. This is to keep the normal intrauterine pregnancy to continue. What if the myometrial thickness was very thin and the scar ectopic was of exogenic type? I may be in need for laparoscopy or laparotomy to excise this cesarean scar pregnancy and the repair of the defect in the wall of the uterus. This is a very interesting case with twins, both of them cesarean scar pregnancy, as you see here. Two sacs deeply inside the myometrium, bulging towards the bladder wall. This is an interesting case published by Johanna in 2016. Lastly, to summarize, please remember we have different lines of treatment. Expectant management is generally not recommended, but if the patient refused to terminate pregnancy and the cesarean scar pregnancy was of endogenic type which developed inside the uterine cavity, but you can continue, but you should tell the risks to the patient and discuss all complications to her, like placenta accreta spectrum, like possibility of horrible bleeding, possibility of occurrence of preterm labor, possibility of occurrence of cesarean hysterectomy. Otherwise, medical treatment like for termination, like methotrexate systemic injection, 1 milligram per kilogram intramuscular in 2 doses, day 0 and day 4, but use it if the HCG level less than 5,000 and the gestational age was less than 8 weeks. Another successful method of treatment is to do aspiration of the gestational sac guided by ultrasound, then insert or infiltrate the sac with embryocyte like methotrexate or potassium chloride or hyperosmolar glucose. Then look if your patient is endogenous or exogenous type. If your patient endogenous, you can use suction evacuation, you can use hysteroscopic resection. If your patient is exogenous and the myometrium is very thin between the sac and the bladder, less than 2 millimeter, then you are in need for laparotomy or laparoscopy for surgical resection and resuturing. Transvaginal resection or laparoscopic resection should be considered over laparotomy where facilities and expertise are available. So take the priority. Lastly, the promising tool, which is a high-intensity focused ultrasound in treatment of cesarean scar pregnancy, should be one of the lines of treatment when needed. This is some of the references. Thank for all publishers for all these important researches. And lastly, thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura